Medurstand. Understanding Medicine.
I am Professor Aziz-ur-Rehman, and today we're going to discuss hemolytic anemias. Hemolytic anemias are not common, luckily, but they, I think, often offer a very challenging case because although the overall hemolytic anemias are not common, but there are many subtypes and it is really not easy to reach the final diagnosis. So I'll see if I can help you to understand this complex disorder and so that you can make a diagnosis in most of the cases. Introduction, what is hemolysis? A normal RBC has an average life expectancy of 120 days. There may be little less, little more, but on the average, an RBC stays in the blood circulation after 120 days, only for 120 days. After 120 days, it will die and will of course be replaced by a new cell. So at any given time, we have almost the same number of RBCs. In hemolytic anemias, because of one or the other abnormality, the cells, they tend to hemolyze much earlier than 120 days. In fact, there is a type of hemolysis called intramedullary hemolysis. That means the cells, they lyse even before they come to the peripheral circulation. Depending upon the severity of the disease, the red cell lifespan may be reduced to a few days. So that is basic introduction of hemolytic anemias. The causes are many and their understanding is very important to reach the proper diagnosis. Okay, the classification of hemolytic anemias can be based on site of abnormality and also based on other parameters. So if you consider the site of abnormality, it could be intracorpuscular. Obviously that means that the problem is on the RBCs or within RBCs, or it could be extracorpuscular. There is hemolysis but RBCs are actually normal. There are many types and subtypes. In intracorpuscular type, there is one condition called spherocytosis. In spherocytosis, the red cells are fully packed with hemoglobin. They are smaller in size because of some defect in the cell wall. They cannot hold any more water. Normal RBCs, they have slightly extra cell wall so that they are bioconcave in nature and they can hold some more water without getting hemolyzed. But in patient with spherocytosis, because of the defect in the cell wall, they cannot hold any more water, and whenever they are exposed to low osmolar states or when they pass through the spleen, they tend to get hemolyzed. Then there could be problem with the hemoglobin molecule, and hemoglobin molecule can have two types of problems. One could be the structural defect, the actual abnormality in the hemoglobin amino acid sequence that would result in some kind of hemoglobinopathies. There are many of them, but sickle cell disease, the hemoglobin S disease, is the commonest. Then there could be qualitative defect in beta or alpha chain that would result in thalassemias, beta thalassemia or alpha thalassemias. They are covered in separate lecture, but they can be considered in hemolytic anemias also because there is a component of hemolysis in thalassemias. Then we may have deficiency of certain enzymes, many of them, but most well known is G6PD. Those individuals who are deficient in G6PD, they are prone to have hemolysis whenever they get exposed to certain drugs and certain situations. So that is another type of hemolytic anemias. These guys, they need to avoid those medication. Then the problem may be extracorpuscular, and the most important is autoimmune hemolytic anemia. In this condition, I call it extracorpuscular because actually the red cells are normal. It's only the antibodies which are made against a specific RBC cell wall antigen which makes them vulnerable to hemolysis. So actual problem is outside the cell. And then hypersplenism, any condition where there is massive splenomegaly, there may be increased red cell breakdown that could result in hemolysis. And then prosthetic valve. Luckily, these days we have very, very refined and fine valves. They do not cause much hemolysis, but the old-fashioned metallic prosthetic valve, they used to cause hemolysis. So this is one way of classifying hemolytic anemias, but there is another way also. That is based on site of lysis. Now, where the cells actually get hemolyzed, they can be intravascular or they may be extravascular. Now, intravascular, so there's certain example. One example is ABO incompatibility. For example, somebody, this should not actually happen these days, but if somebody is transfused with incompatible blood, the different blood group, then there may be actual hemolysis within the blood vessels, immediate rupture of cells, and that produces a classical clinical syndrome. Then paroxysmal nocturnal hemoglobinuria, and this is also a relatively uncommon condition, an acquired disorder where there is actually hemolysis within the blood vessels. And those conditions where there is hemolysis within the blood vessel, they cause actually a typical syndrome of high-grade fever with rigors and chills because pyrogens are released, and pyrogens reset the thermostat, and there is sudden rise in temperature, and there is shivering and contraction of muscles. So that is the typical of intravascular hemolysis. And malaria, in malaria at a certain phase when red cells break down, they release pyrogens, and again the same situation, the hemolysis occurs within the blood vessels. All these three conditions collectively, they are not common. The common one is extravascular hemolysis. Now, in extravascular hemolysis, the classical example is autoimmune hemolytic anemia. Now, what is this condition? Because of some infection, these individuals, they make antibodies against that pathogenic organism, but somehow those antibodies, they cross-react with RBCs. There is perhaps some antigenic similarity. So these antibodies, they coat RBCs, but they do not destroy them until these cells pass through the sinusoids of spleen. Now I'll explain to you the mechanism of hemolysis in this group, but the hemolysis is not actually within the blood vessels. It is outside the blood vessels. These cells which are coated with antibodies, they are engulfed by macrophages and destroyed. Then in spherocytosis also, the cells are destroyed in the spleen, and hypersplenism, again the cells are destroyed extravascularly. So this is another classification. Why this classification is important? Because they actually give different type of clinical pictures. Mechanism of intravascular hemolysis. Now let's see. First of all, in those conditions where there are antibodies which fix complements, they are the ones which will cause intravascular hemolysis, like ABO incompatibility. So once complement is fixed, then there is immediate antibody antigen reaction, and cells are destroyed there and then, right within the blood vessels. Hemolysis within the blood vessels, and there is release of hemoglobin. Normally there is no freely circulating hemoglobin in our plasma. All hemoglobin is within the cells because hemoglobin is very toxic. Hemoglobin is released and it will be taken up by haptoglobin or excreted into the kidneys. LDH is also another indicator of intravascular hemolysis because LDH is normally present within the RBCs. Once RBCs rupture, LDH is released. And then pyrogen is actually any antigen which has the ability to cause fever, so they are also released. Then this extra hemoglobin could be toxic. Nature has made a very good system of scavenging this hemoglobin by binding it to the haptoglobin. Haptoglobin is a protein produced by the liver and it is present in our plasma. It will bind to freely circulating hemoglobin, and then this macromolecule consisting of haptoglobin, hemoglobin will be cleared by macrophages. So as a result, haptoglobin level will be reduced. So the importance of haptoglobin in the diagnosis is that if haptoglobin level is reduced, that is an indicator, that is an indirect sign of release of hemoglobin into the plasma and an indication of hemolytic anemia. Then hemoglobin may be excreted and hemosiderin may be excreted. So these are some of the features of hemolytic anemia. Intravascular. The mechanism of extravascular hemolysis is very interesting. In this case, antibodies are made which are usually immunoglobulin G type. They have specificity against an antigen on the RBC cell wall. So these antibodies will bind to those antigens. Antibodies have two parts. One is AB part, the other is FC part. AB part is the one which determines its specificity. So antibodies will be bound to RBC antigen with their AB part and FC part will be exposed. So FC part, imagine all RBCs, they are coated with antibodies and the antibodies have FC part exposed. And FC part, they're not agglutinating, they're not hemolyzing because they are separate. And once they pass through narrow spaces, narrow sinusoids like in liver and bone marrow, but particularly in spleen, then these FC receptors on macrophages, they recognize these FC part of the antibodies and they engulf it inside and then they destroy it. Normally RBCs are not coated with antibodies. So normally this thing will not happen. Only if there are antibodies which are immunologically bound to RBC antigen, only those cells when they pass through the sinusoid, the macrophages lining those sinusoids, they will bind with FC, the FC receptor will bind with the FC part of antibodies and then will engulf the cell and will destroy it. So in this case, since hemolysis is not inside the blood vessel, you do not get those classical picture of hemolysis. You get slowly anemic symptoms and the symptoms are much less dramatic than those we see in intravascular hemolysis. Pathogenesis, I'm going to explain some of the clinical features, some of the laboratory abnormalities based on certain basic defects. The breakdown of cells, that is what hemolysis is. The cell RBCs, they break down and as a result they cause anemia. Of course, if the red cell span is reduced at any time, less number of RBCs will be present and there will be anemia. Then features of hemolysis, if this is occurring inside the vessels, I told you there will be rigors and chills and fever. But if it is outside the blood vessel, then you may still have these symptoms, but much less dramatic. Then release of hemoglobin itself can cause some of the clinical features and laboratory abnormality. Haptoglobin will be reduced. I just explained that haptoglobin will bind to hemoglobin and will be then taken away by the macrophages. As a result, haptoglobin will be reduced, and that will be used as a marker of hemolytic anemia. Then there may be hemoglobinuria, because some hemoglobin may not be bound to the haptoglobin. If there is over and above that can be bound to haptoglobin, extra hemoglobin will be excreted in the urine. The heme part of hemoglobin molecule will be metabolized into bilirubin, and this will cause indirect hyperbilirubinemia. Patient with hemolytic anemia, they may have slight jaundice. The jaundice is never very deep in these patients, because normally heme is metabolized, the bilirubin is metabolized by the liver, and the liver is very efficient in removing all this bilirubin. But once there is a lot of hemolysis, liver can be overwhelmed, the hepatocyte may be overwhelmed and may not be able to metabolize all the indirect bilirubin. So bilirubin will accumulate in the blood, will cause jaundice, typically mild one. And if you do differential bilirubin, and you would see that indirect or unconjugated bilirubin is increased, conjugated bilirubin is either normal or is increased to lesser extent. Then because there is hemolysis and bone marrow is responding appropriately by producing more cells. So bone marrow will be hyperplastic, and this will be increased. This will show in the peripheral blood as increased reticulocyte count and also macrocytosis. Why macrocytosis? Because the younger RBCs are slightly bigger in size. So when you do their CBC, their MCV will be slightly increased because younger RBCs are slightly bigger. So this explains how hemolysis cause these abnormalities. Now, this is the features common to most hemolytic anemias. You know, these features, they will be present in most hemolytic anemias, but then there are some laboratory abnormalities, some features which are specific to specific type of hemolytic anemias. So on general examination, they will be having pallor and mild jaundice, not very frank jaundice. And other physical examination, they may have splenomegaly, and if they have thalassemia, they may have frontal bossing. Hemoglobin hematocrit will be reduced. MCV, MCH, MCHC may be either normal or may be slightly increased. If there is, if the cells are destroyed, the remaining cells will be of normal morphology. But since then there will be more younger cells coming from the bone marrow, so there would be some macrocytosis also. Haptoglobin is reduced because I just explained it will bind to hemoglobin. LDH is intravascular enzyme, that is also increased, common to all hemolytic anemias. Bilirubin may be increased and mostly unconjugated type. Retic count is also increased. Now, what is the retic count? Reticulocyte is a young 1-day-old RBC which stays in the peripheral blood only for 1 day. Now, if there is hyperplastic bone marrow, that would be reflected as increased reticulocyte count. Now, we have to have correction of reticulocyte count to give it some meaning, and there is a way of correcting RBC the reticulocyte count. You actually measure the reticular count in the particular person, and you correct it for the hemoglobin that patient has. Then there is polychromasia. That means even younger than reticulocyte count reticulocyte cells are present in the peripheral blood. Hemoglobinuria, very rare because all the hemoglobin is either taken up by the haptoglobin or is excreted in the kidneys, but in some cases there may be free hemoglobin in the blood. Hemoglobinuria, hemoglobin is excreted in the urine and that is converted into hemosiderin also, and bone marrow will be hyperplastic. So these are the common features which you would see in all hemolytic anemias. But these are some specific tests. I will not be able to go into the detail, but just to mention, in autoimmune hemolytic anemia, we would have COOMBE'S test, which is now called antiglobulin test. There are two types, the COOMBE'S direct test and COOMBE'S indirect test. I will shortly discuss in some more detail. Then G6PD deficiency, there may be HEINZ body present in the peripheral blood. When you do smear, you might be able to see HEINZ bodies, and you can actually measure G6PD. And this is very important. G6PD can be measured in the RBCs, can be measured in the plasma. Both have their value. So this is another test, but this would be specific to G6PD deficiency. Then in hereditary spherocytosis, RBC morphology is very characteristic. These are small cells but not hypochromic. In fact, they look very, very dense, and their fragility is increased, and I will show you in one of the slides what I mean by that. They become very, very fragile when exposed to low osmolar fluids. Then in paroxysmal nocturnal hemoglobinuria, there is HAM test is positive, and in sickle cell disease, RBC morphology will show sickle type of cells, and there may be abnormality in hemoglobin electrophoresis because you will be able to detect hemoglobin S in hemoglobin electrophoresis. So these are special tests in special types of hemolytic anemias, and in the previous slide I showed common tests which may be present in most, if not all, cases of hemolytic anemias. The diagnosis of hemolytic anemia is always very challenging, as I told you earlier. Now this is the concept of direct COOMBE'S test. Now direct COOMBE'S test is done in hemolytic anemia, autoimmune hemolytic anemia, and this is now called antiglobulin test. COOMBE was the person who described, and antiglobulin is actually the principle of this test. Now these days we call it antiglobulin test. It is direct and indirect. This one is direct. Now what is the purpose of direct test? Determination of antibodies bound to RBCs. Right? Please note down, the purpose of direct COOMBE'S test or direct antiglobulin test is to determine if the RBCs are coated, immunologically bound with antibodies. Now how do we do this? And now this is the patient's sample is taken, and these are the cells, and you can see these cells are coated with antibodies. The FC receptor, the FC part is exposed. FAB, these are like fork type. FAB part, which actually determines its antibody specificity, that is bound to RBC antigen. Okay, so these are all RBCs which are coated by antibodies, but these are not agglutinating. And then these RBCs are washed with the normal saline. Why to wash them? Because even normal RBCs, when they circulate through our blood, they have some antibodies, because antibodies are normally present in our blood. To remove those antibodies, which may be just passively lying there, we have to wash them. We have to wash them in 2 or 3 rounds. So after washing RBCs, if antibodies are still present on these RBCs, they have to be immunologically bound. Now, if there are immunologically bound antibodies, that would mean there is autoimmune hemolytic anemia. So then this is the sample, washed RBCs. Antiglobulin serum is added. this serum contains antibodies against human antibodies. Okay, let me say it again. This serum consists of antibodies against human globulins or human antibodies. Now, if this serum is added to this, only if RBCs are coated with antibodies, only then these antibodies will bind them and agglutinate them. Okay, so if there is agglutination after adding antiglobulin serum, and that would mean that the test is positive, and the inference is that the cells are coated with antibodies, and the further inference is that these antibodies are specifically directed against RBC antigen. So that means that we are dealing with a case of autoimmune hemolytic anemia. This is direct Coombs test. In adults in hemolytic anemias, you will always have direct test positive before you go to the indirect test. Right, so there is an indirect Coombs test also. You could also call indirect antiglobulin test. And in adults with immunohemolytic anemia, this test is mostly not needed because the direct test is always positive before we can consider doing indirect test. Because if you have antibodies, they will bind to RBC antigen only when all RBC antigen sites are saturated. Only then there will be some free antibodies present in the plasma. If you want to determine them, then you will have to do indirect test. But there is a situation where you may have just indirect test positive, and that is a situation where if there is, the mother is rhesus negative and the father is rhesus positive, then the fetus may be rhesus positive. Now this positive cells will go to the mother. This is called feto-maternal circulation. Some RBCs from the fetus may enter the mother, and that will sensitize mother's immune system to make antibodies. Now these antibodies will destroy those RBCs immediately, but antibodies may be detectable. So in that situation, we may be doing indirect Coombs test on mother to see if these antibodies against positive, the rhesus positive antigen are present. Now this is actually the same test. There's a difference that in this case we first take plasma of the patient. In the direct test we took RBCs of the patient. In this case we take plasma of the patient because we want to see if antibodies are present in the plasma. And these antibodies, then we take RBCs from a healthy person, and then we incubate them, and if this serum contains antibodies against RBC antigen, then these cells become coated with those antibodies, and further on the same test is done like direct test. So one step is added, then the test is the same. This is called indirect Coombs test. This will be positive in mother if the baby is rhesus positive, or it will be positive in adults autoimmune hemolytic anemia if the direct Coombs test is already positive. I hope you will find it interesting and will make you understand this test better. Now some morphologies are very characteristic, like HEINZ body is present in people with G6PD deficiency, and paroxysmal nocturnal hemoglobinuria. Patients somehow they develop hemolysis at night. So at night they have this hemoglobinuria, and in the morning, if you examine their urine, it will be very dark because of the hemoglobin present. And then as the day goes on, then the urine becomes clear. So this is characteristic of paroxysmal nocturnal hemoglobinuria. This is the perfect smear of a patient with spherocytosis. You can see all these cells are very small but very dense because they have this spherocytosis. Very, very rounded, unlike bioconcave cells. These are spherocytes. This is osmotic fragility test, and this is done in spherocytosis. Now this is the normal pattern. This is the saline bottles of various concentration. This is 1%, which is slightly hypertonic, then 0.85%, 0.66%, 0.50%, 0.33%. So these are various dilutions. And this is of course 0% mean pure water. Even normal RBCs, they will lyse when they are put in the normal water. Even if they are put in the 0.33% saline, they will hemolyze. But they will not hemolyze when they are exposed to these concentration of saline. In patient with spherocytosis, when these RBCs are exposed to even 0.85%, which is very close to normal saline, these cells, they tend to hemolyze. Because these cells are already full of hemoglobin, they do not have an extra cell wall, and once in hypotonic states, when some water enters these cells cannot hold this extra water and they rupture. So this is the principle of this test, osmotic fragility test. Osmotic fragility is increased in patient with spherocytosis. Now this is the smear in patient with sickle cell anemia, and there is a characteristic morphology of RBCs. You can see very characteristic sickling of the cells. They may be naturally present, or sometimes you have to precipitate sickling by a special test. Serum in hemolysis, in a normal person, if you isolate serum from the RBCs, it should look like this, amber color or yellow color. But in cases of hemolysis, whatever case of hemolysis you may have, the serum would be red. This is not blood actually. RBCs have been removed, but this is the hemolyzed cells present in the form of free hemoglobin. Then reticulocyte count is an important sign of hemolysis. These cells are different than the RBCs. You know, this is a normal RBC, and these are reticulocyte count. Reticulocytes when stained with right stain. When stained with NMB stain, they look different, but both are reticulocyte. This is also an example of reticulocyte. They indicate active bone marrow. When bone marrow is otherwise healthy and is responding to extra blood loss outside the body or within the body in the form of hemolysis, there is prompt reticulocytosis. One even younger than reticulocyte cell type is called polychromasia. You can see, I'm not sure if you can appreciate in the picture, the multiple small color dots, and this is called polychromasia, and this is another sign of hemolysis. A HAM test is test which is done in this PNH, paroxysmal nocturnal hemoglobinuria. When their blood is oxidized, the acidifying agent causes frank hemolysis. This is named after the person who described. You can see in PNH, the plasma, the RBCs, they are hemolyzed as compared to normal people. This is controlled at room temperature. The patient at room temperature, the cells are hemolyzed. This hemolysis occur due to complement, and complement is destroyed at the temperature of 56. So if you do the same test at a temperature of 56 or higher, then this thing will not happen because complement is inactivated at 56 degree centigrade Let's now discuss very briefly the treatment of hemolytic anemia. General measures. These patients, since they have this lot of hemolysis, they need vitamin B12, they need folic acid, and those things which can precipitate hemolysis, they need to be avoided, like in G6PD people, deficient people. Some antibiotics, some drugs need to be avoided. So I think these are the general measure, and sometimes we might have to give transfusion if somebody has severe hemolysis. In autoimmune hemolytic anemia, the treatment of choice is steroid, the first line treatment. Then of course we have to add some other steroid sparing drugs and other immunosuppressive drugs, but first line treatment in immunohemolytic anemia is steroids. Splenectomy may be useful in many cases because in autoimmune hemolytic anemias and in spherocytosis and also in thalassemia, the actual site of RBC destruction is spleen. Although the defect is somewhere else, but that site of destruction is spleen. If we remove spleen, then the destruction is minimized. If this procedure is done early, the results may be better. Of course, once we consider splenectomy, we have to prepare the patient by giving certain vaccine, because after splenectomy these patients are more prone to develop some infection with gram-positive bacteria. So we have to give vaccine to minimize the chances of these infections after splenectomy. And blood transfusion may be needed in some cases. And this is very important in some cases. Bone marrow transplantation and stem cell transplantation may be helpful. Of course, this is a very sophisticated treatment and unfortunately not available as a routine. It is available in our country, but not for everyone. We are now coming to the end of our series on anemias. I have tried to make things easy and given you the pictures of all types of anemias, but there are some cases which are really difficult. There may be some rare disorders, some mixed patterns. You could have deficiency of multiple components at one side at one time and maybe already partially treated. They could also be sometimes challenging. Somebody has already received transfusion. They may be difficult cases. So diagnosis of anemia is easy, but classifying them into a specific category sometimes may be really challenging. Now the summary of hemolytic anemias. Hemolytic anemias are less common but have many subtypes. As I just described, history, physical examination, CBC gives important clues to the diagnosis, but most of these patients would require further tests. Careful examination of CBC and peripheral smear is very, very helpful. Best time to investigate is before you start treating these patients, because only then you will get the clear picture. Once you start treating, then the picture is mixed. For example, if somebody is given blood transfusion, then the blood you are examining is not actually patient's own blood. Part of it is actually transfused blood. So the picture will be confusing. Choose specialized tests as needed to make a final diagnosis. Avoid blood transfusion as first line therapy, because after blood transfusion the treatment, the diagnosis becomes difficult and the treatment also becomes difficult. So transfusions should be given only when they are really indicated. So that was all about hemolytic anemia. This is Professor Aziz-ur-Rehman from Medurstand. This concludes the series on anemias, and very soon I'm going to come up with another series. Please stay tuned, and I'm really looking forward to see you in my next series of lecture. Thank you, Professor Aziz-ur-Rehman from Medurstand.